Kyle earned a Bachelor's of Science degree in Addiction Studies from the University of Central Arkansas, UCA, in 2013, and then went on to use his lived experience with drug and alcohol addiction to become a Certified Peer Recovery Support Specialist, where he led the implementation of this position in an emergency department at the University of Arkansas for Medical Sciences.
Hey, Kim. If we don't mind, if y'all don't mind, if everyone could mute their phones, we're getting a little bit of interference with what Kim is trying to say. And I know for while she's talking, and then when Kyle starts. So if you don't mind muting your phones, thanks.
Thank you, Patty. I'm going to go ahead and mute all, and then I will unmute myself. Can y'all hear me still? Yes. Okay. Fantastic. Okay. So Kyle, as we said, is a certified peer recovery support specialist, where he led the implementation of this position in an emergency department at UAMS. And most recently, he became one of the first 10 certified peer support supervisors in Arkansas. Congratulations on that, Kyle. He also serves on numerous committees and boards to develop and strengthen the Arkansas model and improve peer support services across the United States. And so I just have to say that I've had the opportunity to work with Kyle the last several months, and it has been such a wonderful experience. I have personally learned so much from you, and I'm excited to share for you to share your story today with the ABIN audience. And I can't wait for everyone to hear how important peer support specialists are to the work we do. So without further ado, I will turn it over to you, Kyle. Let me first say, if there are questions, please put them in the chat. We'll be monitoring the chat. Or you can take yourself off mute and ask questions. We like this to be interactive. So take it away, Kyle. Whoops, let me unmute you.
Well, thank you, Kim, and thank you, Jenny, for the opportunity to work with you and alongside you in the programs that you're working on with ABIN. It's been a delight, and I'm just grateful to be here this morning. Thank you to everybody that's tuning in on this call. Wherever you may be, I hope you're having a great morning, and I look forward to having a conversation. Just like Kim just said, I also encourage you to ask questions throughout this presentation. I'm going to share a screen and do a PowerPoint, but if there's questions you have, I would much rather just have that discussion than disseminate information. So feel free to put in the chat box or to take yourself off mute and ask me questions. I'm going to go ahead and share my screen. Can everybody see this? Okay, so what we're going to do is talk about peer support in a medical setting today, and I'll share kind of my experience with that at the University of Arkansas for Medical Sciences, UAMS, and talk about what that may look like in other medical settings, anything from emergency department, primary care clinic, and things like that. So I'm grateful to be here this morning with the Arkansas Behavioral Health Integration Network. Like Kim just read my bio, my name is Kyle Brewer, and in this role, I have a couple different hats that I wear, and I'm actually operating as like the peer recovery specialist consultant with ABIN, and to provide them with any type of consultation or information they may ask me for, and I'm grateful for that opportunity. Never would have in a million years thought that the experiences, my terrible experiences that I've been through, would actually be turned around and used as an asset. So she read my bio. I'm just going to give you a real brief summary of a very long story when it comes to my personal recovery story. I've been in recovery since July 10th of 2017. I started using alcohol and other drugs at the age of 13. At the age of 18, when I went off to college, I got prescribed an opioid, an oxycodone, after my wisdom teeth were removed. I took that prescription as prescribed and called in refills for at least 2 more times. And at the end of that, I was hooked to these medications. And so for the remainder of my college years, I sought out and purchased these these medications at really high rates, use my scholarship money to fund the habit. But I was also really good in school and socially active and, academically successful. So I was putting on this image that everything in my life was good and okay. Like you see, I was actually studying for an addiction studies degree while I'm in active addiction myself. Substance abuse is really prevalent in my family. So I'd seen the consequences up close and personal. And then I was learning about the science in the books. And somehow I was in such denial that I convinced myself that this information didn't apply to me. Well, when I graduated, I learned that no education, no amount of money, no religions, no anything will exempt you from the disease of addiction. And so from 2013 to 2017, my life spiraled, and it spiraled really fast. I went from taking the pills to shooting the pills to moving to heroin because it was a cheaper alternative. Lost everything in my life, destroyed a lot of relationships. And it all kind of came to a head July 10, 2017. I was homeless in my hometown of Benton, Arkansas. That's where I grew up. And my uncle picked me up and dropped me off at a local homeless shelter called the Nehemiah House. They quickly called an ambulance because I was in a drug-induced psychosis, dropped me off at Baptist, which I was sharing earlier that I went to detox through Baptist and went back to the Nehemiah House and entered their 9-month recovery program. They have a faith-based recovery program there. And for about 6 weeks, I did not want to be there. I fought the process, and then I surrendered. I gave my life to God. I gave my life to recovery, and nothing happened overnight. It was a process, and it's still a process that I'm in. But by the grace of God, I have not used drugs or alcohol since July 10, 2017. And I've got the amazing opportunity to take that past, the good, the bad, the ugly, and use it to help other people in a variety of ways. One of those ways being peer support. And one of those groups and people that I get to work with is Ben and Kim and Jenny. And I'm so grateful for that. So thankful that, I didn't lose my life in the battle, because unfortunately that is the reality in so many different ways. And that was not the plan or the intention when the people woke up that morning. And I know for me, for sure, with what I was doing, that could have been the end of my story. But because of my relationship with God and recovery, I was able to find a new life, find purpose. And that's kind of what led me to where I'm at today. So that's a very, very short summary, lots of details left out, but just wanted to share a little bit about me and where I come from. I come from a person with lived experience. I come from the perspective of someone that was homeless, put a needle in my arm 4 years ago. And today I have a new life in recovery. And so I appreciate y'all allowing me to share that, allowing me to be here. The credentials here are Bachelors of Science and then a peer recovery peer supervisor, as Kim mentioned earlier. So the objectives today, by the time we finish this presentation, I hope that you take away a general overview of the Arkansas Peer Specialist Program, the program that I manage with NAADAC. I hope you get a little bit of some nuggets of why we need peer recovery specialists in medical settings and why they may be effective. What that role may look like in a medical setting. We're going to talk about a little bit of role clarity, what a peer does, what a peer doesn't do, and then we'll talk about some of the evolution that's taken place over the last 4 or 5 years when it comes to peer support in a medical setting. So first, we're going to start off with what is a peer recovery specialist, because I think that's a good place to start. Peer recovery specialist is an individual that's living with the disease of addiction and or mental health diagnosis who has experienced and maintained the healing process of recovery. It's important to highlight here that now in the state of Arkansas, there is no substance use peer or mental health peer. Over the last 6 months, both sides of DHS has merged, and there's one path to peer certification, and they are a peer as a peer, and they go through the same training, the same certification. And the criteria to be a peer, you don't have to have a substance use disorder any longer. You can just have mental health and go through the process as well. So that was a big step for the state of Arkansas because there were silos for so long. It's a person who offers support based on a shared understanding, lived experience, respect, and mutual empowerment. A person with strong personal connections to the recovery community. It's a non-clinical role. They're a recovery role model. They advocate for recovery for the people that they serve and for themselves. They're a resource broker, provide a variety of resources for individuals in the community. And they're also HIPAA compliant. So we abide by all the HIPAA rules, CFR 42, and privacy and confidentiality, and the various things that come along with that. I'm going to talk quickly about the Arkansas Peer Specialist Program. This is the program that I manage through NAADAC, the Association for Addiction Professionals, which this contract started at the beginning of this year, where Arkansas has actually over the last four or 5 years with an incredible group of people have developed a 3-tiered, I know this looks like 4, but the first is the training part, a 3-tiered credentialing process for peer support, like a career ladder. So people that are pursuing this certification can advance, and then ultimately at the supervisor level, any of the requirements at these other levels, they can only be signed off on, approved by a certified peer supervisor. So it's the concept of peers supervising peers, because there was a lot of different challenges on the onset when it comes to the clinical and the non-clinical world, supervising and non-supervising and things like that. So there's the 4 levels, or there's the 3 levels, but you start out as a peer in training. And I'm going to go through the next slides. The first 2, I'm going to go through them a little bit more thorough. The last 2, I'll just kind of glaze over because it's the second tiers to the program. But the first 2 are the most important for the beginning of a program. So a peer in training. The eligibility criteria for someone to be a peer in training in the state of Arkansas is they have to have a minimum of 2 years of personal recovery from substance use and or mental health challenges. In addition to that, regardless if they're on the substance use or mental health side, they have to maintain abstinence for at least 2 years as well. This person also has to have an high school diploma or a GED, and we do a background check in the application process. And what's that? Because most of us have a background, that's kind of a prerequisite. So it's not that you can't have a background, it's just you can't have an active warrant, committed a sex offense, or a violent charge like murder. So that's the minimum criteria to begin the process. What that looks like if you meet that criteria for someone in recovery is they complete the core PR application process through NAADAC. That has a $50 application fee. They do a background check that usually is about $20 to $25. Submit those proof of education. The application is reviewed by myself and a review committee, and then we schedule them for core training through Euler Mid-South. The training, they complete the core training, which is a 5-day, 30-hour training where they go over a variety of topics and they learn about the kind of the fundamentals and the foundational principles of peer support and what that looks like. The applicant is assigned a peer supervisor, and at that point, I will issue them their PIT letter that states that they can provide peer services and they can be employed in the state of Arkansas. So when someone, down the road looking for someone to hire, the minimum that they have to have is that letter. And now it's organization to organization, can depend. Do you want someone to be a peer in training, or do they need to be certified? But in order for them to provide services and be employed at all, they have to have that letter at the bare minimum. And when they have that letter, it states that they've done all of these things and they meet this criteria. So once they have that letter, they start their PR, Core Peer Recovery Specialist certification process. They have to complete all the requirements that I just went over. They have to have 46 continuing education hours. They get 30 of those in the core training, meaning that they have 16 additional CE hours that they have to obtain in 18 months. They have 18 months to complete this first tier of the process. You have to have 500 work experience hours, and 100 of those hours have to be domain specific. The 4 domains that we focus on are advocacy, ethical responsibility, mentoring and education, and recovery wellness. These 500 work experience hours can be either a paid position or a volunteer position, either way. And then 25 peer supervision hours that can be done individual, like on an individual basis with a peer supervisor, or in group supervision with your peer supervisor. And all 25 of these hours must address one of these 4 domains. Once you complete those, you then submit your documentation through Oak Tree Supervision, which is the tracking program that we have developed to keep up with all these hours. And we schedule your test with our testing department, and you go take your test either at a testing site, or you can self-proctor it with all this software that they put on the computers, which is pretty amazing. And so at that point, someone is certified at the core level, and someone can stay there and they can renew their credential every 2 years. There's 20 hours of supervision, 20 hours of continuing education that they'll have to achieve to renew every 2 years, and they can stay there. That's totally an individual choice. But if they choose to, they could also start advancing through the program. If they have a goal to become a peer supervisor, they could start going through the advanced credentialing process, which, the criteria for that is have the current PR credential. You submit a application and a letter of recommendation, very similar process to the first one. It's reviewed. Again, we schedule you for a training. Each one of these tiers has a training component that essentially unlocks the credentialing process. So you can't start the credentialing process until you complete the training for that level. So you complete the advanced training, and again, you have some education hours, experience hours, and supervision hours that you must complete in order to take your test and become an advanced peer specialist. And then you can move on to the supervisor level, where you have to have been currently employed for at least 1 to 2 years. The criteria kind of get a little more stringent as you move up the ladder. It requires more letters of recommendation. There's different questions on the applications that we ask and we need you to answer. Again, your application is reviewed, schedule you for training. You start your credentialing process. This one's a little different. Instead of having 500 work experience hours, you have 250 hours of working, 250 hours of actually providing supervision under another peer supervisor. And you're meeting with myself and the Arkansas Peer Advisory Committee to receive supervision and consultation throughout this process. And so I just wanted to go over that because it gives you just the idea of the thoroughness of the process, that peer support is very much a profession, and people are not given these letters or these credentials. They have to earn them. They have to jump through a bunch of hoops. They have to do a bunch of things in order to get to where they're trying to go. And it's a lot of information. So I put this on here. If anybody is interested in learning more about the program, just this QR code will take you to our website, the Arkansas Peer Specialist Program, which will outline everything that I just went through. And it'll also talk in more detail. It'll give you access to the different codes of ethics. We have a code of ethics for the core and advanced, and then a different code of ethics for the peer supervisor because their scope of practice changes. There's the ethics complaint form. There's an ethics enforcement procedure where we have the Arkansas Peer Ethics Review Committee. So when there's an ethics complaint, it's filed, it's reviewed by that committee, decisions are made, and recommendations are handed down to the state. So there's just a really good place, with a lot of information about peer support in the state of Arkansas. Does anybody need me to hold up on this? Are we good?
Kyle, we did have one question in the chat, and that is, who compromises the review committee?
Who is in the review committee?
Yes.
So it's myself and then 2 people from the Arkansas Peer Advisory Committee, and those 2 people will rotate. Currently, right now, it's myself, a gentleman named Casey Copeland, and a lady named Teresa Apple. We are all 3 peer supervisors, and so we'll review and vet the applications and provide any feedback. And then those 2 people will rotate through members of the Arkansas Peer Advisory Committee. Does that make sense?
Yes, that's very helpful. So you're a constant on the committee, and then 2 people will rotate. Yeah.
So as the peer specialist program manager, that's primary responsibility. But we don't want just one person reviewing these applications and making those decisions. So there's multiple eyes on it and giving feedback.
That's very helpful. Thank you.
Yes, ma'am. Okay, so let's get back to the peer support in the medical setting, because that for me, this is a passion. This is where I got my start in peer support, was in the medical setting, and I'm really excited to share with you what that looked like for me. But I want to talk about, I talked about what a peer specialist was. I want to talk about why this may be helpful in a medical setting. So in 2017, the director of the Center for Medicaid and State Operations deemed peer support an evidence-based service to support an individual in or seeking recovery from addiction and or mental health challenges. And so one of the biggest things is that it's evidence-based, and the director of Medicaid and the state operations wrote that into a letter in August of 2017. So crisis moments, I'm sure that most people can relate to this, that in crisis moments in our life, whether that be hospital, jail, or you loss of a family member, or just something tragic, those are oftentimes perfect breeding ground, perfect soil for new seeds to be planted and for people to be open to new information. And so in the hospital, those are prime examples of where people are open to that new information. It can also lead to a decrease in readmissions, repeated usage of hospital resources or your facility or organization's resources. Oftentimes people that struggle with substance use and mental health challenges, they may find themselves in those types of environments on a, almost a revolving door, you've heard it said, because their root problem is not getting addressed, getting medically stabilized, but then the recovery piece and the addiction and the mental health is not necessarily getting addressed. So there's just they're coming back. And so it can decrease in readmissions, which can ultimately lead to financial savings. Non-judgmental approach and the relatability of a peer specialist can increase the individual's willingness to get connected to treatment and recovery. And a peer specialist is well connected to recovery resources, and they may leverage those relationships to expedite the linkage to treatment. So because I'm in recovery and I've been navigated this process, a couple of times myself in the past, I have a lot of relationships with people that work at the various facilities across the state of Arkansas. And I'm sure you can relate to this. There's such a difference that when you make a call to someone and it's a friend on the other line of that phone, rather than just someone you don't know, the person at the front desk or an intake coordinator, and you have no personal relationship with them. So the fact that when someone's seeking treatment and they decide that this particular program is the place they want to look into, and instead of calling, a 1-800 number, I can call my friend that works there, has strong ties there, and sometimes it can just cut through a lot of red tape. And we know that when someone's in a crisis moment and they're asking for help for whatever reason they're asking, we need to capitalize on that moment, and we need to take advantage of that moment. And we need to make that process of getting connected to treatment as easy and as seamless as possible. Another reason for peer support in a medical setting is the ability to spark the ability to ignite the spark of hope through sharing lived experience. So often, over and over, you'd see a light bulb come on when I introduce myself as a person in recovery, and that I've been in this same situation. 4 years ago, I was in a hospital bed and I was in a dark, dark place. And they look at the person in front of them and they don't look like they've been there. They live in a different life. There's just a light bulb that comes on when you're sharing your lived experience, and the other person can relate to it and identify it, because there's certain things you can say where you can only say it if you've actually been in that moment yourself. And when those things start connecting, there's just so much hope in that conversation. And we know hope is a really powerful thing. Providing peer support to someone who has just experienced an overdose could change the course of their life and their recovery. Again, it's that crisis moment and interjecting hope, interjecting options and an opportunity. It could really change that person's life. Peer support complements the medical team and other staff by freeing up their time to focus primarily on the medical issues. So peer support is not here to duplicate or replicate any services that already exist. Peer support is here to complement the services that are already there and come alongside, whether that be a social worker, a nurse, an MD, a resident, whoever that may be. A peer support specialist wants to come alongside this team and use their specialty, which is in recovery, to support the team members that are already working. And while they're doing that and focusing primarily on that, it frees up the rest of the staff to focus primarily on what they're trained and specialized to do. So when we're doing that, when we're all working in our giftings and our talents and in our training and our education, and we're all working towards one common goal, is helping a person find a sustained life of recovery, I believe we're working at our best. It breaks stigma. So in a medical setting, particularly in the emergency department, I realized pretty quickly that stigma exists, but it's not because anybody's bad or someone's done something wrong. It's because when you're in an environment and when the face of addiction and mental health you see is the uncooperative, combative, ungrateful, non-compliant, ripping your IV out, cussing you out, and you're experiencing that on a day-to-day basis as a doctor or a nurse or social worker, that's all you see. It's all you see over and over again. I think it's pretty easy to, it's understandable. I'm not saying it's right, wrong, or indifferent, but it's understandable to see how that would kind of be a negative association over time. It would just have a negative association with it. Because the doctors and the nurses and the social workers, they're all in the medical field for the same reason. They want to help people. That's what they gave their life to do that. But they don't get to really see the down the road story too often. And so by having a peer specialist becoming a coworker, by me coming alongside the people that work in the emergency department and being their coworker, I'm continuously sharing my story with them. I'm continuously sharing the the success stories that I get to experience from the people that they provide services to on the front end, and I share that with them. So it breaks that stigma. It gives them a different face with addiction, with mental health. It gives them, okay, there is, all right, something's working here, and they don't get to hear that story too often. And so I found sharing that story and just being a person in recovery and being in relationships with them, that really helped kind of change that perception. And at the end of the day, it can save lives. And that's what we're all here to do. So peer support, the peer support role in a medical setting. This is just a little circle chart. So if someone would meet someone, link them to resources, provide education, offer additional resources, maintain contact, and it's a continuous circle. And it doesn't end. When peer support services end is when the person that's receiving them wants them to end. It's completely voluntary, that the person has to want the services. They have to be willing to receive the services at any given time. If they're like, I don't want to receive services anymore, then that's completely their right to do that. And that's their own choice. But until that, we will walk alongside, not in front of, not behind, but right beside this person. We will walk with them through the process of recovery, whatever that may look like for them. So a typical way that this would look for me on a day-to-day basis at UAMS is I would engage with and listen to individuals who have survived an overdose, that are experiencing alcohol or drug withdrawal, and they request support for issues related to substance use. I discuss multiple pathways to recovery. So now I come from a faith-based program. That's the program that ultimately changed my life. And so my personal recovery story leans strong on Christ-centered recovery. But that's just my story. That doesn't necessarily mean that has to be your story or that it will be your story. So my job as a peer specialist is to present the variety of options of recovery that I'm familiar with because of my training, because of my relationships, because of my involvement in the recovery community, and let you choose what your pathway to recovery is. Because I know that I was told for a long time that this is what I should do, this is how I should do it, this is what's going to work. And that really never got through to me. But I believe that if you give someone the ability to make their own choice, come up with their own idea, that they are much more likely to succeed and to implement that idea because it was their idea. We advocate and empower, advocate for the individual that we're providing services for. We advocate just for recovery in general, and also empower the individual that we're working with. So oftentimes when you're in that situation, that you've lost all power. All power has been taken from you. You are powerless over these issues and these challenges. And so just putting the ball back in this person's court and giving them the power and giving them a voice in their treatment, giving them a voice in their recovery, and helping, kind of bridge that gap between provider and the individual that they're serving through shared decision-making. Again, we discuss this. I don't tell someone what to do. I don't necessarily make suggestions. All we do is talk about the options. And in that shared decision-making process, they decide what is best for them. And then we go from there. They guide that conversation, and we link and refer them to preferred recovery resources and act as a bridge between the primary care clinic, from the hospital, from the emergency department, and provide general education about addiction and recovery by strategically sharing lived experience. So one thing that I did early on at UAMS when we were trying to implement the program, I started going around to just random rooms that were in the emergency. This is obviously pre-COVID. So it was a little different during COVID, but pre-COVID, I would just walk into a room and I would share that my name's Kyle Brewer and I'm a peer specialist, meaning that I'm a person in long-term recovery from substance use. And they weren't there for anything related to drugs or alcohol, but I would just start sharing about the opioid epidemic and the issues going on in Arkansas. I'll talk about the prescribing rates. I'll talk about naloxone and share about that resource. I would just share my story a little bit because my story is essentially the opioid epidemic. That's kind of my experience was. And so I would share that with the general public and without fail. And I almost would bet on it. If I asked a question on this call, several people would raise their hand or put their, hand emojis up. If most people, if it's not directly affecting their lives, it is indirectly affecting their lives from a friend or family member, someone they go to church with, someone they work with. Everybody's been touched by this. There's no, this is the great equalizer is addiction and mental health. Everybody has somebody that they know or they are personally faced with it. And so providing that general education to the public is also real helpful. Go
We
ahead,
have
Kim.
one question, excuse me, which was, do peer specialists also work with families?
Yes, peer specialists do work with families. Like that, kind of what I was just talking about. I would be talking to family. That would usually be the case. It would be a mom or dad that would say, you remind me of my son. My son's got this problem, and we've been really struggling with what to do, how to do it. And so providing them support and getting them connected to resources like Al-Anon. I mean, really one of my go-to people is my mother, because my mother walked through that as a mom, and she had to make some really hard decisions about, cutting me off. And she never gave up on me, but she let me go for a period of time, for a few years, where she had to go to Al-Anon, and she had to learn about enabling, and she had to learn her part in the process. And so getting them connected to other people, other family members that are currently and have gone through that journey themselves is absolutely something that we do. And Arkansas has such a thriving community of family members who have lost loved ones to the disease of addiction and have turned that around and using it as a purpose and a platform to just share resources and help other people that are going through that. So long answer to your question, but yeah, we absolutely work with family members. I see Chad has a question. Any info about the distribution peer specialists across the state? Are there areas where we need more? About the distribution, I'm thinking that what you're asking is just kind of what where peers are at across the state. And so I can put this in the chat box right here, artakeback.org. Go to the opioid response dashboard. We have a map on there under peer recovery. You can go into every county and it will give you every person that's been trained. There's over 400 people that have been trained. And yeah, there it is right there. And they will show you their level of training, their level of certification, and certain levels of certification. Then we put their contact information on there. And so you could contact them. But you will notice that I believe there were 26 counties like in the last couple of months. I think we've hit 2 of them. So I think we might have 24 counties where we don't have peer specialists trained. We don't have someone in that community that's been trained. So there's absolutely a need, particularly in Southeast Arkansas. I would say that that's probably the greatest need or the biggest gaps when it comes to peer services. But there are counties scattered around that do not have peer specialists. I'm going to get to this referrals and documentation. I'm going to get that's in the presentation. So salary range, peer specialists. So there's a tier level. So best practices for a peer in training is somewhere between the range of 30 to 32,000. Certified peer specialist is 30 to 35, and advanced is 35 to 40, and a supervisor is 40 to 45, 40 to 50. All of that is starting range. Those are just best practices that this is continuously evolving and growing, and it's something but that's on average where people are starting at, and everything, including education, experience, their different talents, all that can influence that just like any other job and can increase it or decrease it. So go through a couple more of these. It supports and strengthens, the peer support can support and strengthen the continuity of care. So after discharge or when the person's not in the primary care clinic, the peer support specialist can go out in the community, can go have coffee, can go to a recovery meeting, can stay in contact with them on the phone, can do things that, maybe the traditional staff member in these settings aren't able to do. And so you're able to follow through and kind of be more involved and active in this person's personal life. You can assist in improving the dialogue between the individuals and the medical staff. Like I said earlier, bridging that gap, educating the medical staff on recovery. Again, that's like what I was talking about earlier about just being in relationships with coworkers, and break stigma. That's on here twice because that's a big deal. We're going to go through role clarity pretty fast. Let me go back. So what a peer specialist is and what a peer specialist is not. A peer specialist is not a doctor, social worker, counselor. So we don't provide any of those services that person may provide. What we are is a person with lived experience. We do not document in the medical record, and I will talk more about that when I get to documentation. We are a role model for recovery and positive change. We don't give medical advice. We don't diagnose, assess, or treat. We don't tell a person how to live their recovery. We are voluntary, meaning someone has to want our services. Our relationship is based off equality and mutuality, and we motivate through hope and inspiration. We do not use clinical language like patient and client. You have not heard me say those words, and it's very intentional. We do support multiple pathways to recovery. We use recovery-oriented language based off lived experience. We function as an advocate, and we share knowledge of recovery resources. We do not motivate through fear or consequences. We do not give money to people. The referral process. And so the referral process may look different. And what I'm going to talk to you through is the referral process that we developed at UAMS. And keep in mind that when we started, there was an idea of what it may look like. 6 months into it, it was completely different. It was, once you get in it, once you start doing it, things change and things evolve. In my referral process, and so I supervise about 6 peers across the state that work in other hospitals: Jefferson Regional, Bradley County, Unity Health, River Valley Primary Care, Saline County. And so their referral process, there's some similarities, but there's some differences too. So keep in mind, what I'm sharing here is what I did at UAMS, but it also may need to be taken and molded and shaped to kind of fit whatever organization or hospital that you may be trying to implement it at. And so it's multifaceted. That's one of the most important things. It's a multifaceted referral and consult process, but every one of these processes leads to the peer support visiting or contacting the individual interested in receiving services. And so a doctor, an RN, a patient caretaker, or a social worker contact me via my phone, email. A Vocera is the little thing that they use at UAMS where you can just push a button and call someone, or secure chat through Epic, their charting system that they use at UAMS. They could send me a message through there. The peer support reviews the ED track board. So I would come in to the hospital, I would review the track board, and on the track board, it would state their chief complaint, meaning why this person was in the hospital. Why is this person in the emergency department? And there were some key terms that I began looking for that I got familiar with: ingestion, which was an overdose, a drug and alcohol assessment, psychiatric B, because they call the psychiatric area of the emergency department UMS the B area. And so those were some words I would look for, and they may flag me to go approach that room and to ask the person if they would want to receive services. I acted as an extension of the psychiatry consult team. So whatever is already in place with an organization or hospital that they're using when they're providing services to people with substance use and mental health challenges, just be an extension of that. So if the psychiatry team learned real fast that they're going to be talking to a lot of people that are going to be interested in my services, so then they would offer the services when that came up in the conversation, when they got down to the root of things and realized, okay, this is someone that wants treatment for substance use. We have a person that's, been in a similar situation. Would you be interested in talking to him? And so the psychiatry consult team and the care management and social work team both ended up doing that, and it got implemented to both of those systems of care. And also, like right now in the emergency department, my card is at the social work and the psychiatric nurses desk. They're in the emergency department, and every person that comes through there that is going to be seen and discharged for whatever reason, and they have substance use disorder and they're interested in receiving services, they're going to leave with my number. So even when I'm not there, they're able to give out my contact information, and people are able to reach me and reach out to me. So that's kind of how the referral process looked at UAMS and how it currently looks at UAMS. But again, it can look a little different depending on your organization. A schedule. So what does a schedule for someone in this thing look like? Well, for me, full-time, it was 40 hours a week, 32 to 36 hours were at the hospital, with 4 to 8 hours flexed in to be away from the hospital for those coffee, meetings, for those going to the recovery meeting. It's a little bit, out of the norm, right? There's not you're not usually going to get coffee with someone and that's on the clock, but for peer support, there are things like that peer specialists may do. And then a part-time, you would just adapt that to fit the 20-hour work week. The idea is just to be flexible and evolving. You may start with 2 p.m. to 10 p.m. That's where we started based off of when naloxone was administered in the emergency department. But once I started implementing the program, we realized that like 10 a.m. to 7 p.m. was a better time to accomplish the goals that I was trying to accomplish, because that was when the resources that I was trying to get people connected to were open. And so we realized that when someone would come in at 8 or 9 o'clock at night, that I could be there for that emotional support, which is very important. But essentially, they were being discharged and there was nothing I could do. So they're able to call me at that time now instead. So that was just something that just kind of evolved over time. The idea, though, is that you have to determine what the best time for your organization is and create a schedule for them to be on the hospital grounds and to also be away from the hospital. Let's see, Patty says, does the peer support specialist share information with the medical team, or is the confidential commitment to the patient the priority? And I said, okay, so yes to both those questions. So this is the way that it would go for me. If someone's sharing information with me, obviously the empowerment piece, I want to empower that person to be open and honest with the provider, because they probably don't have they have a misconception of the provider, that they can't trust the provider. So through conversations, like I try to empower that person to share those details. If there's something pertinent to their treatment, being honest, the provider can't help us unless we're telling them everything that's going on. And so the first step is just to empower that person to share the information themselves. The second step is, if they don't want to share it themselves, ask, do you want me to stay in here with you and we can share that together? Or we can share that together, or I'll share it with you or for you, but we're together. So basically getting consent, or, the last step would be, if they didn't want to share it at all, then I would ask for their consent to share it. But when someone comes into, I know at UAMS, they sign off to give everybody that's on the team, it falls underneath the same confidentiality. So we're all on the same treatment team. And so even though if it really came down to it, they had already given us permission to share information with one another. And so as a peer specialist and the people I supervise, I tell them, you don't share the details. There's no sense of sharing details about someone's story. You don't have to do that. But the action steps and what we're doing and all the pertinent information as far as treatment and their medical care, share that information and be very, very thorough with your communication with the doctors, the nurses, social workers, because they need to know what's going on, as far as you can't just start some discharge planning, and you need them to know about it. And so it's that collaboration, that working together. So really answer yes to both those questions. Let's see. So documentation. So this is always a really hot topic. So it's non-clinical documentation. What I mean by that, it's not the traditional, we're gonna write notes about someone without having, it's the idea of we're not sitting behind a desk and they're telling us them things and we're typing on a computer. So we would never document in the presence of the person we're providing services to. We'll always be outside of there. And the other piece is that we don't necessarily document in the medical chart. And I know in the medical community, this is where I kind of get into some well, how does that work kind of conversations. I do have access to Epic in the medical charts, very limited access. I don't need all access to all those different things, but I see their face sheet, which gives me information about their insurance, about their demographics, but I can put into my documentation system. So our documentation system that we created at UAMS, not created this system, but what we used is REDCap. REDCap is a documentation or a form system that they use for a variety of things and a variety of different settings. But we went in and just set up some forms, an initial contact form that was basically their demographic information, and then a services form, which basically provided very general information about what services we're providing. It wasn't personal identifying information about the people that I was providing services to. And so REDCap is what we used. And now REDCap is also what the state has partnered with AFMC to use to document in the variety of their jail and hospital programs that they fund. But with that being said, I was in the documentation more times than not because of my thoroughness of communication with the rest of the team. So social workers document in a medical file, doctors document in the medical file. And when I'm the one communicating with them, just by default, that would end up in the note. We talked to peer support, Kyle Brewer. This is what they're doing, going to treatment. They're going to make these calls, follow up in the next day. So, the whole thing would be outlined in the medical documentation. I just wasn't the person putting them in there. Documentation is important, though. It was the documentation. I'll share the data with you here in just a minute. it was that documentation that ultimately funded the 5 positions that are currently in the state of Arkansas and other hospitals outside of UAMS. So documentation is important for a variety of reasons, but it also is important because it produces funding streams for peer support and recovery services. Supervision. So what does supervision look like for this person? There's going to be dual supervision that happens. Most likely there will have to be a certified peer recovery peer supervisor that they get assigned, like I said, at the beginning of the process, that they'll work with through their peer support stuff, their peer support certification. But at the hospital, you'll have a direct supervisor that works within the organization. So the peer supervisor is most likely going to be outside of their agency or organization. Like, I don't work for Jefferson Regional, Bradley County, Unity Health, River Valley. I don't work for those organizations, but I do supervise their peers. They have a direct supervisor, like mine was an attending, that had a vested interest in psychiatry. His name's Dr. Mike Wilson, and he was my supervisor. He is my supervisor. So it could be a medical director, a charge nurse, an attending, or care management lead. There's characteristics that you're going to want to look for, because this direct supervisor, the one within the organization, is going to be a very, very important piece to the successful integration of peer support within the organization. You're going to want them to be a respected leader in the organization, for them to be knowledgeable about recovery and the peer support role, for them to believe in the position, the ability to think outside of the status quo. You want them to be someone that advocates for peer specialists and has a strong relationship with the medical team and the colleagues, that their voice, their opinion, their perspective matters, and people respect their perspective and their opinion. You'll have weekly or biweekly meetings with your peer supervisor, as well as weekly to biweekly meetings with the direct supervisor. So there's thorough supervision. They're going to be getting supervision from 2 different places. The supervisors play a key role in the successful integration of peer support in the medical setting. So this is the data from the first year of the program. So in 1 year working at UAMS, I approached 524 people. Out of that 524 people, 501 of them agreed to have a conversation. Most time people are open to have a conversation. As you'll see, not everybody is wanting treatment. Not everybody is ready to get help, but I'm able to plant that seed. I'm able to give them my contact information. 212 of those people requested assistance for substance use disorder. I directly linked 105 of those people to treatment, meaning that we got them accepted into treatment and got them everything from transportation, basically got them to the door. All they had to do was walk in the door. And any type of linkage to treatment is included in that, whether that be outpatient, whether that be an MAT program, whether that be inpatient treatment, long-term, short-term, all those different types of levels of care and levels of treatment. And another 112 people were referred, meaning they weren't necessarily ready to take those real action steps at that particular point in time, but they wanted some good information about specific programs. They kind of had an idea what they wanted, and I would give them that referral that, hey, this place are good options. Will meet your needs. They'll take your insurance, or you don't have insurance, so they're state funded. You need an ID, a social security card, a proof of income, all those types of things. And then the other piece of the program that we did at UAMS was give out naloxone in the emergency department, a box of 2 nasal sprays. And so over that year, I gave out 191 of these boxes, which ended up being 382 doses of take-home Narcan, take-home naloxone, just in the emergency department while they're there. It was a resource that we could offer for them to have for free. They never have to go to a pharmacy. They walked out with the box. I tell you, that was just such an incredible part of the program, to be able to put that in people's hands from the emergency department. So I started the program at UAMS, started working there in 2019. And I was the first person in the state of Arkansas to be employed in this position in the emergency department. So it was just me. Today in 2021, we have peer specialists at Shy St. Vincent's Infirmary and Bradford Health. They have an addiction recovery program within their hospital that they employ multiple peer specialists. Jefferson Regional Medical Center in Pine Bluff has a peer specialist in their emergency department. Unity Health, the Harris Medical Center in Newport, has a peer specialist that works on their psych floor and will respond to their emergency department. Bradley County Medical Center in Warren has a peer specialist in their emergency department, and hopefully soon they'll be working with Drew Memorial as well to provide services there. River Valley Primary Care Services, which is a primary care clinic, has multiple locations. They have a peer specialist that responds and provides services at these locations. Saline Memorial Health Foundation is the newest person to be added to this list, and they will be hiring soon a peer specialist that will respond to both Saline Memorial and the new Heart Hospital Encore there in Saline County. Last time I Googled this, I've learned something that we have over 50 hospitals in the state of Arkansas. And as you can see here, there's 2, 4, 6, 7 on this list. So there's a lot of work to do. And this is not including the hundreds of primary care clinics and MAT clinics that we have across the state. So there is a big need, and we are just getting started. But you can see just in the last 2 years, we've made a lot of progress, and there's a lot of evolution going on when it comes to peer support in this role. I want to give a special thanks to the Arkansas Department of Human Services and the University of Arkansas for Medical Sciences. The Department of Human Services is the funding partner that made this position possible at UAMS. UAMS was the organization that believed in the position and hired me and allowed me to implement the program. I want to give this little testament to the program real quick that funding is not always there. Somewhere along the way, grant funding will go away. That's what happened. So UAMS, we had a program that was really successful for a year. You would have never thought that funding would go away. We did any and everything we could to go above and beyond to make funding possible. Well, we all know how grants work. Sometimes they're there, sometimes they're not. One day they're there, the next day they're gone. So it went away. It did not get renewed or extended. And so when they went around in the end of 2020 and were sharing this with the team, with the resident meetings, the attending meetings, the social work and care management meetings, and they were sharing that this resource will no longer be there. The hospital got so much negative feedback about that decision that they then went back and extended their own funds to continue the program because of the success of the program. And they realized that it was effective because of the feedback they were getting from the people that the peer specialists worked with. And so that's just a testament to the position. It's just a testament to the effectiveness of the position and how it can be really helpful in that setting. So I think I've left us 5 minutes for questions. Sorry, I know I went through a lot of things fast, but I realized we were getting close to time, and I did want to allow some time for questions. I see there's 6 comments in here, but thank you so much. And I would like to answer any questions, starting with this one. It says, are insurance companies paying for this service? So that is not a battle. I don't want to call it a battle. That is a conversation that we are having every day. Right now, we're working with Medicaid. So we have DHS state leadership all the way up to Director Gillespie, bought in, sold out, believing in peer support. And so we are, the mental health and substance use sides of DHS are both in active conversations with Medicaid to get this service reimbursable through both sides and through our model. Currently, there is a Medicaid billing code for mental health peer support, but not substance use. Are there any peer support specialists in ambulatory care settings like primary care? So yeah, primary care, there are a variety of primary cares across the state. So UAMS has a bunch of MAT clinics that they provide grant funding from. UAMS like a pass through for grant funding. And those MAT clinics, several of them, I can't name them all, have a peer specialist that works there. And also River Valley Primary Care up in Clarksville, they have multiple locations in that area of the state, has a peer specialist that works there as well. Well, we have over 100 hospitals is what Ann said. Yeah, I'll have to update that. I would love that list. How do you balance working 10 to 7 and responding to ER for calls throughout the week? Do you ever rotate call? That's a good question, Kim. So balance is important for anybody, but especially someone that's in recovery. And so my coworkers obviously are very mindful of that as well. And so if someone comes in through the night, they're getting my contact information, and if they call and I'm asleep, I can't answer, right? But I call and follow up that next day. So I will return phone calls if I get them and if I receive them. But also I think my coworkers kind of set that up and say, hey, give this person a call, this time. And they kind of try to shield me from that. I did have a coworker at UAMS. Now it's just me. And now I have a whole nother full-time job. So when you talk about balance, I'm learning. And people have always told me that when I figure it out to let them know. So yes, it would be great to have more than one person doing this, because as we know, the need is great and the demand is there. What is the process for verifying the mental health stability of a person seeking to become a peer support specialist? So the process for just recovery, basically, whether it's on the mental health substance use side, is self-attestation. And so they answer several questions on the application about their recovery, about their experience, those types of things. But when it comes to saying, hey, I'm in recovery, I identify as being in recovery for substance use or mental health, they just sign and date it. And they also sign and date for the abstinence. And then our process, you go to training for a week, you get connected to a peer supervisor. If someone's being dishonest about that, our process should bring that out. And then an ethics complaint would be filed, and that would be taken care of. So we just kind of have to trust the process on that, and it's just based off someone self-attesting to it. And recovery is one of those things that outside of the abstinence requirement, recovery is one of those things that whatever recovery is for you is what recovery is for you. The only like really measurable that the state of Arkansas has in place where it's like, it's pretty clear is abstinence.
Kyle, what does abstinence look like for the mental health side? I mean, it's pretty obvious on the substance abuse side, but for the mental health, what do you use to kind of guide that?
Yeah, it's the same criteria. And this was one of the back and forth conversation between the substance use and mental health side, because I'm sure the reason that you're asking the question, I mean, it's a common one. It's just no illicit drugs or alcohol. That's just kind of the standard. And again, the way that they verify that is they just sign saying that that's true. I think I got medical marijuana. No, medical marijuana is not allowed because marijuana is federally illegal, and we use federal funding for a lot of our programs. I saw someone had said they need my Deborah, need my car as my coworker, and I would love to visit with you. My contact information is right here. So please, if anybody wants to talk more, this is my email address. That's my cell phone number. You can reach out there if there's anything I can do, or if I can help get you connected to someone that may be in your area. I'm here to help in any way that I can. And Deborah, I can get you those cards that you're asking for.
I had a question come through to me, direct messaging, and we can't figure out how to put it in the everyone chat, but I'm just going to read it to you. It says, great presentation. Thank you. I'm a substance abuse counselor and have spent hours on the phone looking for a treatment center that would accept a client needing and wanting recovery, but run into roadblocks with pay source, mainly insurance issues and no funding. Do you have any resources for such cases?
Yeah, and without knowing the specifics of the individual, this is where I would start working with people. So if someone has AMBET or Blue Cross, one of those plans, we're kind of up here. We're at wide array of resources throughout the state or even out of state. A lot of people that I work with are uninsured or underinsured. So then we'll go down to, okay, if you don't have insurance or you have Medicaid, because unfortunately Medicaid just doesn't pay for a whole lot of inpatient substance use treatment or any that I know of. But then we would look at state funding. So if someone has an ID and a social security card, whatever county that ID's address is in would tell you what catchment area of the state. I believe the states are broken out into 6 to 8 catchment areas. I can't remember. But whatever county that address is in, it will tell you, hey, this person qualifies for this program to receive state funded treatment. They can receive that with that ID and a social security card. Well, we know too, common. We don't have an ID. We don't have a social security. We got all of our stuff stolen yesterday, Okay. Well, this may not be the right fit for everybody, but the point is that you can offer this resource. Faith-based treatment programs will accept you with nothing. They'll take you in like where I was at. I had nothing to offer. I had no insurance. I was homeless, and they would take me in. And we have a lot of relationships with faith-based programs. And so there's, you start up here with all the options. Then you go to state-funded treatment with when they don't have insurance. And if that can't work either, then you can offer faith-based programs. And if none of those fit, you can simply just offer personalized support. But I guess what I'm getting at is if in those 3 different processes of offering resources, if someone is saying no to all of those, then there's a good chance that this person doesn't want to go to treatment. And that's okay. But so my point is that I always try to find something that's there, even if it may not, like, I'm not a big on God thing. Like, I wasn't either, you know, but like right now with the limited resources, this is the only thing that we can find. And if you want this, we can get you there. But if not, then let's figure out how to go to the DMV together, get you an ID. We can get the letter off the website, the Social Security office that states you've ordered a new Social Security card. And so with that letter and your ID, we can get you state funded treatment. So, you know, there's kind of a lot of different processes that I would go through is trying to figure out what the best resources were. And then if it's opioid use disorder, particularly if someone has an opioid history, there are all kinds of grants for outpatient treatment, and particularly for MAT treatment if someone has no insurance or little insurance.
Okay. Well, Kyle, thank you so much for your time this morning. We are, like I said, we're so grateful that you're here and sharing this program. This program has generated so much interest from the ABIN audience. We've received lots of questions, so I'm so grateful that you were able to be here today and answer those questions. And, you know, as I listen to you talk, part of what I'm hearing is that peer specialists are really fairly new to Arkansas and new to the availability of resources that we have. But as we hear you talk about the individualized work, this is absolutely what's needed when someone can't get in a treatment facility, but maybe they can get connected with the peer specialist to provide them that support and walk them through until they can get maybe more intensive treatment. So thank you. Thank you for your time this morning. Thank you for working with us. And if anyone has questions, please reach out to Kyle, reach out to us at ABIN, and we'd love to assist you and get you connected any way we can. Have a great day.
Thank you all.